So hi, everyone. I'm Shreya Palakar. I'm Senior Director of Provider and Health Plan Partnerships at Tyto. Over the next 30 minutes, I'll be moderating a deeper discussion of senior and specialty care, the ability to extend round-the-clock care access to places that don't typically have, easy access to providers. Today, we're joined by Deanna Larson, who's the CEO of Avera eCare, a part of Avera Health System based in Sioux Falls, South Dakota. Avera eCare is one of the world's leading telehealth providers. They're delivering a broad range of offerings and services, including emergency triage, ICU, pharmacy, senior care, behavioral health, correctional health, school health, specialty clinics, and the list goes on. Over the last 25 years, Avera eCare has actually developed an innovative model and network to meet, Avera's unique needs as a health system, as well as to provide millions of telehealth encounters across hundreds of sites nationally. And Tyto and Avera eCare have worked together for years to really improve access across a variety of their programs spanning schools, care facilities, and senior care, and inpatient rounding. So I'm about to turn it over to Deanna. Just one housekeeping item. We'd love to hear your questions for Deanna. If you could put them in the Q&A tab rather than the chat, we'll be able to try to answer as many of those as possible. So Deanna, I'll turn the floor over to you. Thanks so much for joining us.
Well, thank you for that wonderful introduction, and I'm really happy to be here overall. It's a great day for telemedicine, and I'm really delighted to be here in front of all of you for Tyto, and we have partnered with Tyto for so many years. It seems like a very long time already, and really been, had wonderful experience. So I'll share some of that. I am going to give a little bit of an update on our process today. We did, and talking to some of the leaders at Tyto, we've taken a little bit different perspective in the presentation today, and to talk more broadly about the use cases for telemedicine, and really understanding what's happening here during the pre-COVID and post-COVID time. I'm not going to focus a lot on COVID. I'm going to focus on the use cases for telemedicine. So great to be here with you today, and we'll go ahead and get started. And you can see the titling that I've actually chosen here is kind of what are the aims and what are the applications and how do we really support adoption. And I know that you've all been through a lot of these processes in telemedicine, but these pieces of work have been very important and influential to us here at Avera eCare. So the first piece I'm going to talk about here is the aims, and I'll point you to the bottom of the page. We've kept this, what I'll call mantra, focus and purpose, for our aims for over a decade now. And most important to us is that we really truly understand these aims. And when I talk about access to care, and the workforce sustainability and the improved outcomes of care, and also the cost reductions, those are really serious and important to us. And every time we think about the application of a telemedicine program or supporting a local team with telemedicine, we always want to go through these aims to make sure, are we really making a difference in these 4 segments? And then on the top of the page, you really see those customers, and I would actually add a 4th one here. So it would be, of course, the patients we serve, and then secondarily, who are the clinicians we're augmenting in the care of those patients, and maybe what health system are they interacting with or possibly employed by, and 4th, who's the payer? So now you have all of that big stakeholder group that's really interested in improving access to care so that the care can have the best potential outcome that it can have while supporting the local workforce and overall reducing costs. So you can see it's really important as we're engaging with telemedicine that you're taking all of that perspective into place, especially as you start looking at where do we want to maybe land post-COVID. Possibly during COVID, you took on a lot of telemedicine, and now you're rebounding back to brick and mortar. And so how do you land in the middle, and how do you really understand all of these important aims as you set out to take your next step into your strategy for telemedicine? On this page, you see a lot of eCare's application, and I'll just ask you to kind of look at that 2008 number in the middle of the page. And on this slide, you see, I would point your focus to 2008. And that's really where you started to see from Avera eCare, the organization of the company as we are today. And today we're a company that reaches across a broad geography that I'll show you in the next slide, serving much more than Avera Health. And the purpose that we have is really those aims that I just brought forward on the previous slide, but reaching outside of the Avera Health network. Since 2008, we really started to develop many 24/7 service lines, being pharmacy, emergency, ICU, and even senior care, where we're available to local patients and or clinicians, providers to support and augment their care locally, available 24/7, that the nurses or physicians or clinicians can call for us to be a colleague in supporting the care locally. We also continued on with that in the hospitalist, and then started to do scheduled visits with the school nursing and at the clinic sites. So all of that has been a decade of really becoming that virtual care leader and understanding where there is really a lack of access of care and where there's support needed locally to augment care and services. And where do we find ourselves today is really in that post-COVID world. And what's happened, early on, specialty clinic was very important. And certainly, we were doing that out of clinics clear back at the Avera Health organization in the 90s, late 90s, supporting pulmonary care and cardiovascular, et cetera, one-to-one, one patient and one specialist. But post-COVID, there's so much interest in how do we really deal with primary care. And that has a lot to do with our experience in senior care, really supporting and augmenting local providers to take care of residents in the skilled nursing facility. And then post-COVID, it's what is the consumer demanding in their primary care, and how do they want to be able to reach out to a primary care physician or family practice physician to support them in their care needs. And we often used to think about urgent care only, but if we can keep the consumer connected to a provider, primary care provider, we know, of course, that they're going to likely at some point in time need brick and mortar, but how do we continue to support their care, augment their care through that virtual access? On the next slide, what I wanted to make sure and put a vision out there for all of you who are really interested in telemedicine. The backscape that I just shared with you gave you a lot of perspective on who we are and what we've done over these years. But what's really important, I think, is that different from probably many organizations, Avera eCare had the vision of moving outside of the landscape, if you will, of the footprint of the health system. The health system resides in the upper Midwest in those 4 states. And we have gone on to do contracted services with all of these states with the clinical services that I just described to you. And what we've always held out and very important to us, are we making a difference, and can we, again, support patient care and providers out there? And I think the reason I'm bringing this forward so strongly in this conversation today is that you really need to, what place does telemedicine have within your health system? And you can't flip the switch, so to speak, and have everything turn into virtual, but how do you integrate into what you have currently and understand that several health systems across all of this geography are dealing with that integration and understanding how to utilize telemedicine within care for their patients. And this is kind of this adoption strategy that I'll talk to you about, for your perspectives and your consideration. If you look at the top of this, we talk about eCare and now some continued, how did we think about this and adoption from a strategic standpoint? And initially, we really looked at, what were our service lines? Where were we seeing a gap in care that really needed some workforce support to do the continuation of care and making sure that care was integrated into, telemedicine was integrated into the clinical service line like ICU or emergency. When a need was identified, it could be responded to immediately and worked in collegially with the local people. So that was our really first foray into kind of understanding these use cases for telemedicine. And then we realized that the nation really needed to have more research and understand, well, what impact we're really having. And then lastly, now we've started to do a lot of education so that we can help educate around the nation on some of the worldview, if you will, of how to really set up telemedicine practices. Below, I want to make sure that this also needs to be a local consideration. I use the Baldrige criteria to really frame up this organization, and I think it's important that as you're thinking about adoption of a telehealth strategy, what is your leadership really thinking? How is it bedded into your strategic plan? That's really important because the resources and there's differences of opinion about the use cases of telemedicine, and there's still, of course, a loud voice around reimbursement. It's still fee for service, and so how do you still integrate some telemedicine practice, understanding that the consumer wants that, giving consumer choice around where they'll receive their care. They may like brick and mortar. They may want some of the consumerism piece and ease of use and via telemedicine. And so how do you integrate and combine those, understanding both what your own people think internally as the workforce and what does the external workforce really think about that. And then, how do you operationally put that into your health system or whatever it is you're trying to develop around telemedicine? There's a lot of aspects to that, which requires a lot of data. Now, I wanted to point out for you, for our own organization, we have to think about, what is not only the operations of the, 300 or 250, 300 staff I have here at the but also as we contract with local companies, what do their leaders think? What's their strategy? What is their goals? How do I augment and support their workforce? Now, the reason I say that is because if you go into, if you think about how we're doing it here at eCare, you may need to do some of that within an organization. How does the pediatric service line really think about utilizing telemedicine, and how can we as an organization understand how they would like to be augmented or supported so that they can best integrate the telemedicine? It sounds really simple when you talk about it, but getting into operations and a deep level of that, you'll find out that you'll have resistance and kind of impedance to the process of getting things operational. So digging really deep on those questions and understanding what the risks are for those clinicians, why they're seeing it as not the best option for their staff, very important aspects to take forward as you're thinking about implementation. And then what do you really measure to help move the workforce in a direction that helps them understand, why telemedicine has made an impact for them? On this slide, you see us measuring access to care. So the top is, door to provider time, and the differentiation of this happens to be the ED setting. And so how quick in those 16% of the critical access facilities in America, we're showing you the difference of how quickly a physician-aborted ED doc is available to the patient entering into the emergency department when we're called versus the lighter line or the other line showing you when the provider locally would have arrived. And sometimes that's just fine, but if you're talking about heart attacks, strokes, and are they arriving locally latent or later, why are they doing that? They're doing that because they are also a clinic provider. They're also maybe the hospital provider, making rounds in the hospital, also providing care at home. And so how do we really support them, augment them, and be a colleague to them, and then be starting the care of that patient before they arrive, and then again working in tandem with them when they do arrive. So really big piece there, bringing out a data metric on access. And lower, we're also showing you just the support that we're providing in that same group of patients in the emergency department when we're assisting with first pass intubation rates, which intubation, tubing, putting a tube into the airway of the patient, which really is the difference of life and death. And in telemedicine, they're again understanding how to really get ourselves linked into the intubation, the video intubation access, so that we can see what the local provider can see when they're actually intubating and help guide and direct that. Things, early access and good outcomes with early intubations ultimately saves a lot of healthcare dollars, because we aren't having the downstream delay of impact, delay of care impacts that potentially cost us more financially. This slide also another piece that I just like to bring forward, that research piece. So how do we really make sure that we're sharing with the nation again? How are we impacting workforce? And in this particular slide, you're seeing one of the reports that we gave out and was actually published about the impact that we're having on recruitment and retention into those rural communities. In this case, it was the use of telemedicine and retention of U.S. physicians. So you can imagine pre-COVID and now post-COVID, again, giving collegial support, really helping them to understand. You have a colleague, there's someone here that you can work with and talk with, and really bringing that into real practice has both extended careers as well as assisted in recruitment of physicians into those communities, knowing again that they wouldn't be working in isolation because of the component of telemedicine. And big data points, if you're going into telemedicine, it's really good to have, the administrators, the clinical teams, really understanding what are we doing with this telemedicine. Is it just to be in the mainstream that we're doing this? Is it consumer only? Consumer numbers are really good. I just don't happen to have them on this slide, but consumers are definitely identifying that they want access. But here you see some very technical types of improvement in care and outcomes and numbers that you can talk to clinicians about in their participation both locally and in collegiality with other providers across telemedicine, that they really do have huge impacts on overall outcomes of care. And these are great sound bites, again, for all across all the stakeholders to really embrace and impact. This last soundbite I want to make sure we mention is telemedicine is also changing some of the models of care. And I'll talk about the senior care one here a bit before we go into the one that's on the screen. In senior care, we have made ourselves available 24/7 in the skilled nursing facility. And so what's been so important about that is I often talk about seniors who live residentially in those skilled nursing facilities. They're pretty fragile, and as they have a change of status, I like to think about it very much like a neonate kind of patient. So what that means is you need to assess that change quickly, and the nursing team needs access to physicians to make sure that what the next step of the plan might be or what the next intervention is. So being available to them really our nurse practitioners, the RNs call the nurse practitioners, they have a video visit, can make a determination if the patient, what intervention needs to take place locally. Do they really need to be seen in another brick and mortar location? What can we do locally? Really reducing those on-plan transfers by well over 50%. I think our number on the last slide said 60-some%. So it's really important from a cost perspective, but also we're able to really reduce all of the situation of unnecessary hospitalizations and all the sequelae that really occurs with residents in those situations. We've also found that in those situations, our RN staff, maybe because in a skilled nursing facility, they don't readily have a lot of interaction many times with the primary care provider. So they're calling into a clinic, and the clinic setting is very busy. They have a full schedule of outpatients, that they're seeing for the day. So how does that resident skilled nursing facility really get prioritized is always difficult. And of course it's attempted, but it's difficult. So if we can be there when the nurse calls in, do an assessment with them, have them have the confidence that you can call anytime, you're not interrupting us, we're here available for you. We've actually seen them become much bolder and confident in their assessment of skills and early calls and early interventions, really reducing some of that sequela that can occur as those fragile residents have to wait for care in other settings. And on this situation here in front of you in the screen, you're really seeing another change, another model change that's actually occurred. And this was in some of our rural communities, we were really struggling with, as I said earlier, recruitment of physicians into those communities. And they may be one of a couple, 3, 4 physicians who come into the community, which means they're really always on call, whether they're at church or at the grocery store. And so, and the reason for that is they're supporting the community. That means the clinic, the hospital, and the emergency setting. And so again, I talked about collegiality earlier, and some of the change in the model is that they are now able, because of some work that we did with CMS some years back, to really utilize nurse practitioners to support the 24/7 model of the emergency department, to be the first provider that they see in the emergency department. Certainly the physician is available and to come in if there's a situation that requires the MD to come into that environment, but also the relationship between the boarded ED doc here and the Avera eCare Center and that nurse practitioner can have the patient starting intervention immediately. Let's just say it's a heart attack, and them packaged and ready to transfer possibly by the time the local provider gets there. Again, they retain all responsibility as far as being the primary provider for that patient. We're then in there more or less like a consult, really supporting that care and working and augmenting the local provider. So it's been a change of the model in many of our critical access facilities, really the adoption and integration of nurse practitioners into the emergency model. And this is really my last slide here, and I just kind of wanted to end here because as you're thinking about going forward with your telemedicine programs, I wanted to bring up what we've done with Tyto, specifically the Tyto card here, and what the relationship has been. We've been with Tyto for so many years, kind of iterating and processing what the use cases are for the Tyto equipment. It started way back when we were wanting to make sure that we could hear through the otoscope and stethoscope, and that we could really see what we wanted to see, and what they were doing was just awesome. And then also, what's the network look like? What does the video look like? What's the uptime? You can see the agility of the card here, the adaptability being for us, the use cases in our schools, the use case. So in our school setting, we have a layperson actually, firing up the equipment and setting the student up with the nurse here in the center, really making that very available to them, and the ease of use is important. The footprint that we take up is small. We also use this in the skilled nursing facility, again, having the nurses have a very agile piece of equipment that's dependable, comes up very easily when they need it, and also we're using it in our hospitalist program. So part of the reason I wanted to mention all of that is because it's really important that you're working with a provider or a tech company who will help you with that agility. Those different applications of where you want to use the technology needs to be discussed so that they understand, I might be in a noisy school where I really have to be able to hear. My clinicians are kind of fussy. They want to hear all the heart tones. How do I make sure that they can do that, and making sure that they'll take that feedback? And also this can be used in the home. And so, making it so easy that we can have patients it's a smaller device, but the same platform in their home setting so that they're able to make calls on their own, and it's not just difficult to do. And the last thing I'll say is, I never want to overlook how you implement something within an organization. And right now in Avera, even though, they're kind of starting to, how do we land post-COVID? And so what's important is, we put physicians oftentimes at the table to figure out, what is it that they want to do virtually. And I'll just say, I've got the tech company up on here. I've just mentioned physicians. I'll say make sure you have all of the stakeholders there. Asking physicians to lead teams is, of course, very important, but it's also very important to remember that the physician, where their huge genius aspect of care is, they walk into a room and the patient's there and ready for them. Think about an emergency department. The patient's brought in on the gurney. They're probably already exposed, clothes off, ready to take care of whatever's being presented. In the clinic setting, the patient is disrobed and ready, on the exam table, and the physician knows, here's what I'm going in for. The minute they walk that room, whether it's in a clinic, whether it's in an ED setting, whether it's in a hospital setting, they're starting their assessment. They're looking at the patient, looking at maybe the part of the body that's exposed, and starting to do their thought processes in those first seconds, all the way through several seconds, to determine what they're going to do next for that patient. So why am I saying that? Because if we have them enter a patient engagement and they have to worry about what the lighting is, what the sound is, what button to push, how to make things happen, that's a big distraction for them. So I encourage you, when you're starting to think about telemedicine in your own shops, make sure you have the right representatives there, the IT folks who really understand what physicians need and want when they walk in the room, the clinicians that support the physician, that might be nurses, medical assistants, nurse aides, or schedulers for that matter. How do they support the patient and the clinician to get into that situation where the clinician is walking into the room and the patient and the clinician are ready to engage in that encounter. So I encourage you to think about that. Pick the company that's ready to put you in that situation between you and the clinician, the provider and the clinician, to make you ready and not distracted by what's not working with your technology. So thank you for that. That's my last slide.
Thanks so much, Deanna. That was a really helpful overview. I think in the little bit of slide snafu at the start, we may have missed slide 2, so would love to see what you were sharing as part of the.
Sure. So this was the one where I kind of mentioned at the bottom there, that's improve access to care. You're always trying to improve workforce recruitment and retention, of course, impact the outcomes of care. And in doing that, you'll reduce the cost. And at the top, I identified on there, I said 3 customers, patients, clinicians, and I said health systems or healthcare. But I would also add payers to that, are also the customers.
Great. And can everyone, you can respond in the chat, but can everyone see the slide now? Great. So then another question from the group is around cardiac rehabilitation. And if you know anyone who's doing cardiac rehab, using Tyto at some of the remote sites.
I do actually, I don't know that I can give you names right now off the top of my head, but I can sure get those to you. I am aware that some cardiac rehab has started with some technology. I think actually Tyto may be aware of some of those as well. And what they're doing is actually, it's much like the PT that's happening. It's a little bit more difficult, of course, because of the monitoring and at what phase of cardiac rehab are they taking it home. It's in the later phases that I'm aware of.
Great. And then, I think a question, you've shared a lot about the operations, and how these programs run, but just, if you're thinking about this as a group that's looking to build one of these programs up from scratch in senior care and specialty care, what is some of the, most important advice that you would give one of those groups, some of the key table stakes things that they need to think about as they're going about setting this up?
Mm-hmm. So some really, a couple of early things are, who is your stakeholder group? So if you're going to bill, make sure, where's your EMR? Are you going to be within your EMR or external to your EMR, and does it matter? I would say it doesn't matter because the physician is very adept at using something like I showed you on that last slide alongside their EMR, but know what is the expectation. So part of that is, are you going to bill or not bill? I'm a B2B company, so I don't bill patients. So just have to know that. And then who's the rest of the stakeholders? What clinicians? I mentioned earlier, make sure if it's do you need the scheduling team to be involved at some point? What does the physician medical staff say? Let's say you're going to a primary care clinic. Do you need all 10 primary care providers to say, I'm going to do virtual? I wouldn't go there. I would pick your couple of really great experts or, forerunners who want to have their patients be involved in telemedicine. Start with those 2 or 3 or 4, and then let the rest come in. When you try to broadly, administratively do top down, believe me, we've done this, the naysayers will win. So go with the ones who want to do this. Make sure you have that team assembled at the table. The other part is what IT, what are you expecting to connect with? Have your IT team there? Are you, going on your local network? Are you going on internet? What is the expectation of what you're going to do? Have your HIPAA compliance piece. Have all of those people assembled so they can take their role. And lastly, I'll reemphasize, don't expect physicians to do all this. They're great. They're genius at taking care of patients.
Thank you. And then, there's a question around the TytoCare cart. So, I know you shared a bit of your cart, but would love to hear kind of how you came to that decision. Is there a Tyto cart that groups can use that has Tyto as video and peripherals?
Sure. Well, first of all, Tyto comes with all the peripherals, so you should always know that. And Tyto, since we're talking Tyto here, they definitely could help you with the cart, either development for the use case that you're wanting to apply it to, or could certainly replicate what you saw on that slide set.
Great. And then this is, probably the last question, but of course, we can take questions as well via email and try to get those answered. Do all of your, we wanted to hear a little bit more, I think, about Tyto home kits, and just how you think about distributing those out. Are there certain populations or payers that are better suited for kits at home?
So two populations quickly I would address. So the first population is the high use cases with comorbidities that need a lot of titration, maybe COPD or CHF, great use case to start with. The other is moms, new moms, OB, new moms. They have a lot of calls, a lot of needs. So think about going, putting it in your Best Buy, which is probably where you could go to buy it. Think about including that in your insurance plans. How do you really incorporate that, reduce your overall cost of care by having them show up at brick and mortar, but yet having them satisfied and actually appropriately titrated for the care that they need?
Great. Well, thank you so much, Deanna. This was a wealth of knowledge. We really appreciate you sharing it with us. Any other questions, you can feel free to email TytoCare, and we look to, seeing the rest of the summit today. Thank you again.
Thank you. Have a great day.
All right, take care.